So hello, my name is Bronwyn Reid McDermott. I'm the Senior Technical Officer in Simulation for the National University of Ireland Galway and ICAPS, which is the Irish Centre for Applied Patient Safety and Simulation. And I'm giving this presentation on behalf of myself and my colleague Connor Carey, who is our AV and Simulation Technician. And we're going to talk about the challenges of developing a flexible simulation space on a clinical site and some of the lessons we have learned. So just to give you a bit of background about who we are to start, ICAPS is a collaborative group from across the Sálta University Healthcare Group and from NUI Galway. So we cater from learners across Sálta, which is made up of the hospitals from 5 counties on the kind of west and northwest coast of Ireland, with around 10,000 staff in total. And then we also support the undergraduate curriculum, medical curriculum at NUI Galway School of Medicine. So that's a 5 or a 6 year programme, which has around 200 learners per year. Prior to this build, so this picture on the right here, we were based on 2 sites. So we had a small hi-fi sim room and an associated debrief room or a classroom on the hospital site, which is shown kind of by the smaller green circle and the purple dot here. So the green circle is the hospital site, the purple dot is where our sim suite was. And we also had a kind of a large and a small skills teaching room on university campus, which is the bigger circle with the purple dot. Our new facility is under development, and we're going to talk about that today, and that's where the pink dot is. So I suppose for context, each of these locations is maybe a 10 or 15 minute walk from each other. A quick overview of our timeline. So Professor Byrne, our Director of Simulation, and I had been planning to take over the world and build a simulation centre long before there was ever any actual hope of it happening. So for a number of months and probably years really before we began this build, we'd visited a lot of different simulation centres, both within Ireland and internationally, and we had taken lots and lots of pictures and asked a lot of questions about what worked and what didn't work in these facilities. We were given the thumbs up to go ahead with the build in summer 2020, and that's when we started meeting with the architect and buildings and CAE to develop a plan. Over the course of around a year, we went through multiple iterations of design plans, and then finally the build began this summer, May 2021. We're now at the point that the structural work is done, and we're in the process of having learning space in the AV system set up and installed, with the hope to be up and running for January of next year. So it's worth noting that the timeline of this coincides beautifully with the COVID timeline in Ireland. Our first lockdown began in March 2020, and this kind of has had a huge impact on the project throughout, which I'll talk about as we go on. Our aims, so when we embarked on this project, we had some aims, and our first was to create a facility that is functional as a simulation lab. So for us, this meant the ability to deliver high and mid-fidelity simulation, clinical and procedural skills, as well as more traditional teaching methods like PowerPoint presentations and didactic learning. It also means the ability to cater for multiple different learner groups. So we have both postgraduate and undergraduate learners, and our groups can range in size from maybe 6 to 10 people to, again, classes of up to 200 in the undergraduate medical school. We needed a facility that was able to deliver just-in-time training and that's bookable by learners for independent practice. And finally, functionally, as with any sim centre, we needed a facility that had adequate storage, utilities, waste management and so on in order to function. We really wanted to create a space that was flexible, so to have learning spaces that were not restricted by their functionality. We know that no centre can run simulation 100% of the time. It's impossible, and having rooms with really confined abilities means a huge loss of space and it's not economically viable. So we needed to be able to deliver all forms of simulation across as many rooms as possible, task, mannequin, SP, as well as traditional teaching methods, and we needed to be able to cater for vastly different learner groups and to be able to turn over the rooms really quickly to maximise functionality and occupancy. Finally, we aimed to create a space that would be future-proof, so both in the context of a pandemic and then with the changes that this has brought in online and distance learning. We needed to be able to face the challenges of delivering face-to-face simulation when COVID rates are at their highest, and then ensure we had the ability to deliver synchronous and asynchronous online learning and be prepared for future cohorts of learners and faculties who've really embraced this technology. This is what the plan for the building looks like. So just very briefly, we have 3 large kind of flexi skills debrief teaching spaces at the back. There's a simulated operating theatre with an adjoining observation room and control room here. An SP control room down the bottom left corner and 3 SP rooms, a debrief room. The central block has 2 mannequin SP rooms, which function as kind of inpatient rooms, and a joined control room, a surgical skills room, and then we have some spaces for decontamination, storage, getting changed, and a technical office space. Here are some pictures to show you what we started with. So this was a retrofit, which posed some challenges structurally. The original design was done in 1992, and it had taken kind of an industrial style architectural design. So as you can see, there's these kind of concrete waffle ceilings. There's a lot of breeze block or exposed block walls. Ducts and services are exposed throughout the building. So this posed a challenge not only visually, because the area looked in no way clinical, but practically, as there was no way for us to put in wiring in the ceilings and cameras and microphones and things like that. Other things were obviously not right. The floors were all carpeted. There was very little existing storage space. Other than the practical and the visual challenges, I think one of the biggest challenges we faced was an emotional one. So as it so happened, the architect who was procured to design this sim centre with us had also been the architect who did the previous build in 1992, and he was extremely attached to the original design he had created, and I think a little bit upset that we wanted to change it. In order to meet our aims, what did we need to do? So in order to create something that was functional, we needed the ceilings dropped to allow cameras and mics and wiring to be embedded. We needed the walls plastered and the exposed ducts and services concealed. We needed storage capacity increased, and we needed acoustic panelling on the walls because the acoustics in the building were horrible. We wanted for flexibility to have wipeable floors in all rooms, and we learned that there's actually various different types of vinyl, that you can get acoustic vinyl and anti-static and all different sorts for different rooms. The acoustic considerations came in with the walls and the flooring, and actually adding storage to rooms helped with the acoustic considerations too. We wanted really high counters so that we could easily tuck away trolleys and turn stuff over, and that we had better flexibility in being able to turn the room over easily. From a COVID perspective, we needed to look at ventilation. We added a lot of decontamination and cleaning facilities, and we needed to consider flow and access and egress routes, changing facilities, and hand wash sinks. So I feel a little bit like my mum here when I used to bring a friend home from school without warning, and she was saying, please excuse the mess, but this still is a work in progress, so please do excuse some of the mess in these photos. We've managed quite successfully to overcome the structural challenges that the building posed. So as you can see here, the floors have all changed. We have these lovely high counters, we had a huge blind schedule of things put in. Certain things we retained. If there wasn't a need for it to look clinical, then we retained some of the waffle ceilings, and we retained some of the breeze block in some of the rooms. But most of them we have this kind of dropped ceiling and these acoustic panels put in. I think the biggest lessons we learned here were firstly from other centres, from visiting and asking them what worked, what didn't work, and being really sure in ourselves of what we needed. The second biggest lesson was how important it is for your architect and buildings to be brought in and understand what you're trying to achieve. So we brought the team to other sim centres, we brought them to different departments around the hospital. I even have a really good photo of our architect scrubbed in theatre so that they knew what we were trying to achieve, and they were on side with us with trying to develop it. When it came to furniture and fixtures and fittings, we collaborated really closely with HSE procurement to ensure the hospital equipment we were getting was representative of what we've seen in real life. As it turned out, we ended up being able to get a lot of equipment for free that was no longer able to be used on the hospital site. For flexibility, we put everything on wheels: beds, chairs, tables, and so on. We have adjustable height podiums and tables in the rooms so that they can flip between demoing skills, standing and sitting down. We have room for trolleys underneath the counters. We had lockable storage for security so that we can safely allow students into practice in the space in the evenings. From a COVID perspective, it was masks, wipes, gel dispensers in all the rooms, and we had to be really careful that everything was wipeable, so vinyl on chairs and soft furnishings. We know ourselves from delivering skills in sim over the last few years how important mobile furniture is and the ability to do a quick turnaround. However, I think one of our biggest lessons learned here was the benefit of engaging with the HSE procurement in ensuring that the equipment we got was correct and actually being able to repurpose old equipment as well. Um, so audiovisual considerations are a huge part of this, and CAE has really helped us here. For basic functionality, we fit each mannequin and SP room with digital and optical cameras, speakers, phones and phone capture units, DCUs, monitors, microphones. From a flexibility perspective, we wanted to make sure that we were able to see and hear what was going on in all the rooms and that there could be two-way communication between them. So we added a camera and a mic in all of them. But we had to also make sure that the basics were there. So each room has the ability to present, to do video playback, to do basic AV and PowerPoint presentations and things, because that's traditionally what these rooms have been used for. Future proofing. So we wanted the ability to broadcast sim and skills demonstrations across all the rooms within the building, and to be able to have two-way communication between the learners. We wanted to be able to broadcast remotely and again have that two-way communication, so someone can speak into us in a debrief that's happening in the room and we can talk back to them. And we wanted the ability to record and create learning materials because we saw through COVID how important pre-course learning was. I think the biggest lesson we learned here was again around engagement with people. So a huge amount of work from CAE and our local IT support needed to be done in order to ensure our sim centre was functional. Having local IT support on board with the process is really, really important, and I think I would recommend doing this from a very early stage. So I'm going to very briefly fly through some of the other challenges that we had and what we learned from them, and then we'll take some questions. So the two major challenges we faced were COVID and a cyber attack. COVID impacted hugely on delivery times, access to the facility, quarantine and travel for colleagues coming from abroad. Nationally, a cyber attack on the HSE in May and then locally on NUIG in September meant that we were left without a network, which has hugely delayed our AV installation. I'm not sure there is much of a lesson here, other than to tell you to expect the unexpected. And when you're embarking on a project like this, you need a really strong team that can keep a cool head and be flexible when things go a little bit bad. Language and terminology was a challenge. So the language we speak in SIM is different to any other language, and terminology is a big issue. At the beginning of this whole project, the word simulation itself confused people so much that we had to call it a clinical visualization project. We had huge issues with one-way mirrors and trying to establish an understanding around which side of the mirror is which. So the picture here on the right is of, I think, our fourth attempt at getting this right, which was actually a really interesting process to watch, but we eventually got there. In the same way others don't understand the language we speak, we certainly didn't understand some of the language other people spoke, like the architect or AV or even CAE. So the photo on the left here shows Connor, our AV tech, Kevin, the head of systems and technology, and staff from Drama by Design and CAE, and our professor Dara Byrne, all working out the AV systems in each room and the touch panels and everything like that. Again, the lesson here is that buy-in is important, and it's really important that we all understand what we're trying to achieve and what we're coming from. And even if language is a barrier, it's so important to ask questions and try and get to grips with the terminology from both sides as best you can. Transport is a major piece of the puzzle when you're moving department. Our two existing sites have only stairs and no lift, so transport has always been challenging. The photo on the right here shows hospital services staff pushing a leak microscope up the back ramp of our current facility. Amber, one of our techs, is there pushing an ECG machine across from anatomy or our university site to the hospital site. We continue to deliver teaching while the building is being developed, which means that the timing of equipment transport is really important as it's currently in use. So at times we need things on one site on one day and then on another next, which means a lot of kind of back and forth. Finally, a lot of the equipment that needs to be transported are simulators, which are really delicate or really, really heavy items like an anesthetics machine that need kind of specialised transportation. We have ended up doing a lot of the simulator transport ourselves. Mike, who was mentioned in the last presentation, is also a volunteer with the Galway Swan Rescue. And on Saturdays, we've been using the van between calls to transport simulators over. CAE should be able to clock some of their blue phantoms in the back of the van here. My biggest piece of advice here is make a list and a timeline of what's to be moved. In order for any company or services department to transport equipment for you, you need to have an itemised list with dimensions, with weights, and you need to be able to coordinate the timing of this with a fine-tooth comb. There are some items that will need to be transported carefully or quickly. So again, a team that's willing to make it work and a friend with a van are always an asset. Storage-wise, structurally, we're really happy with our storage capacity and learned a lot from other centres. So you can see here that we have kind of mortuary-style racking for the mannequins. We have a lot of pegboards to hang things on. Roller storage, which we learned from our colleagues in our CSI, is really good. My key piece of advice here is this is prime time to redo your inventory. So label everything, generate a file, and track what you have and how much you have as you go. My other tip is to finally get rid of the skeletons in your closet. So all simulation centres have equipment or mannequins that are out of date or no longer in use. And there's lots of organisations that are really grateful to have these. So this pic on the bottom right here is of us giving some old IV arms to Olivia Byrne, who runs the local RNLI or the lifeboat service here. And they'll use these for training of their team. But there's also schools, Scouts, Order of Malta, and loads of different people that will be interested in the equipment. Final tip is testing. The importance of the dry run in simulation can never be understated, and it's the same with a new facility. So these photos are from our first surgical skills program for scientists, which was both a pilot program and a test of the facility. So everyone involved was really on board with how new things were and aware of it and really willing to give feedback. It is really only when you start running programs that you realize what you're missing. Simple things like sharps bins and pens and bin bags and things like that you just wouldn't think of, and we found it really beneficial to do this. We're not in a position to run a hi-fi sim just yet, but we're hoping to be able to do this in mid-December so that we can have tested the entire facility before we reopen in January. So here's a nice picture of the team in their hard hats and their high vis on site. I would very briefly like to take this opportunity to thank everyone who's been involved with this project from an architectural perspective, buildings and services, from AV, our colleagues in CAE, our colleagues in simulation centres around the country who allowed us to visit, and very much so a thank you to my own team at ICAPS for supporting this insane but exciting project. So thank you for listening, and Connor and I are happy to take any questions that you might have.